Hello, can you start the session? First, presenter, Mr. Govind Prakash. Mr. Govind Prakash. Sorry. Dr. Priya Vasan. Next, we have Dr. Samiksha M. It's a request, please upload your PPT before to main desk. Uh, Dr. Nazwa Shirin, have you uploaded your PPT there? Please request who are the speaker.
22 patients representing about 37.1% of the total had hypertension. 208 patients constituting 11.1% had reported with headache. Out of the 758 type 2 diabetes mellitus patients, 156, that is about 20.5% of them had diabetic retinopathy changes, and out of which 112 patients had normal visual acuity that was below 6/9, and 4 patients were diagnosed with proliferative diabetic retinopathy. Primary care physicians play a crucial role in managing diabetic patients within the community. They should promote initial eye examinations at the appropriate disease intervals and refer patients to ophthalmologists. With diabetes lacking a complete cure, primary care physicians serve as patients' initial community contact. A well-planned health education intervention changes the knowledge in physicians. With a change in knowledge and structured referral system, there is a significant increase in the number of referrals and the attendance of patients for DR screening. So this study shows the need to mobilize and link physicians in the general hospital with the high hospital. Conclusion, our study aids in fostering a comprehensive and proactive healthcare strategy by addressing the awareness divide among various medical disciplines. This facilitates early diagnosis of diabetic retinopathy and ensures timely care delivery. Thank you.
Anyone is ready with PPT? Anyone is ready with Dr. Shubham Saurabh? Okay. Who uploaded PPT? Okay.
Good morning, judges. I am Dr. Aishwarya Gavit, and I will be presenting my e-poster on analysis of 100 patients coming for disability certificate at a tertiary care center. So blindness is a serious.
Good morning all. What is unmasking CNS relapse in B-cell ALL, the crucial role of ophthalmologist. In the modern era, there have been remarkable advancement in the treatment of children with acute lymphoblastic leukemia, leading to exceptional success rate. However, ALL relapse is a significant concern and is the second most common cancer among children. Central nervous system is the second most prevalent site of ALL relapse. We present an 8-year-old boy, B-cell ALL survivor, completed chemotherapy 15 months ago, presented to our OPD with history of persistent headache and double vision for 1 week. On examination, child had a visual acuity of both eyes 6/6, anterior segment were normal, extraocular movements were restricted on dextroversion, dextroelevation and dextrodepression. Diplopia charting and Hess charting were suggestive of right lateral rectus paresis. Fundus examination showed bilateral established papilledema. We advised MRI brain, which showed minimal contrast enhancement in the right cerebellar hemisphere and in the pituitary stalk, suggestive of leukemic infiltration. These findings were confirmed by CSF analysis. CSF cytology was positive for malignancy, morphology suggestive of lymphoid blast. CSF flow cytometry showed co-expression of CD10 and CD19 in 95.7% of blood cell, which is consistent with B-cell ALL. The child was immediately started on chemoradiotherapy based on standard protocol and exhibited a favorable response. Ophthalmologists are familiar with the commonly observed leukemic retinopathy and orbital infiltrations in patients with leukemia. With advancement in aggressive chemotherapy and radiation therapy, involvement increased in patients experiencing CNS and hematological relapse. As in this case, ophthalmologic manifestation may be the sole indication of leukemic recurrence. In our case, the child presented with persistent headache and double vision, which prompted ophthalmic evaluation, leading to a timely detection of CNS relapse. While visual acuity may remain unaffected initially, the presence of characteristic signs such as extraocular movement limitation and abnormal fundus finding may arise the suspicion of CNS pathology. Prompt recognition of these ocular signs helped us to move on to further investigations like CSF analysis and MRI, helping us in a timely diagnosis of CNS relapse. The successful management of our patient underscores the importance of a multidisciplinary approach involving ophthalmologists in the comprehensive care of leukemia. This case underscores the critical role of vigilant monitoring for ocular symptoms as potential indicator of CNS disease or relapse in pediatric ALL. We emphasize the importance of routine fundus examination in ALL patients. Enhanced awareness among healthcare professionals and caregivers regarding the significance of ocular symptoms can facilitate early detection and improve outcomes for children at risk of CNS relapse following B-cell ALL treatment. Thank you.
Dr. Mansi Shah. Her presentation on endophthalmitis pulse for junior resident beyond clinical decision making.
Good morning. My topic is endophthalmitis, pearls for junior residents beyond clinical decision making. Introduction. In India, postgraduate education solely focuses on diagnosis and treatment of disease entity. Important aspects related to patient care like communication are not taught or evaluated during residency. We know that good communication with the patient builds trust, improves compliance, and reduces medical legal action. The importance of good communication and significance of doctor-patient relationship is demonstrated in this case, and the passive points noted by the junior resident beyond the clinical management of the dreaded complication of endophthalmitis are highlighted further. The case. A 77-year-old diabetic female came with the complaint of sudden painless loss of vision in the left eye since 3 months. Her vision was hand movement close to face. Her slit lamp findings were normal. On 90-day examination, a yellow glow was seen. On direct ophthalmoscopy, left eye vitreous hemorrhage was diagnosed. She was posted for the left eye vitrectomy under local anesthesia. The surgery was uneventful. Post-op day vision was 624, which improved to 618 on pinhole. On day 2, she started complaining of loss of vision. She had tenderness over her eye, and on slit lamp examination, we saw a severe AC reaction. We did a B scan, which showed mild exudates suggestive of endophthalmitis. So now what we did next, first we counseled the patient to have a strict diabetic diet since her BSL charting showed deranged glucose. We immediately posted her for a vitrectomy and gave her intravitreal antibiotics. We repeated intravitreal antibiotics. Our aggressive approach resulted in an outcome with the patient finally getting 624 vision after 3 weeks. She maintained that vision. So the discussion for today, the pearls that were gathered during the case included effective counseling focusing on the comorbidities was extremely important, prompt investigation for the suspected complication, skillful breaking of the bad news, transparent communication regarding complication, ethical conduct throughout the episode, honest, reflective approach to hypothesize the cause of the complication, high patient confidence allowing an aggressive approach, extremely compliant patient, a regular and frequent follow-up. This resulted in a satisfied and a well-informed patient. The discussion, due to the high number of patients an Indian doctor in training deals with, very little time is given during each clinical encounter. A lot of emphasis is given for the diagnosis and quick treatment. However, good communication is the key to build trust and a good patient-doctor relationship. Conclusion, important soft skills, especially communication, professionalism, and ethics should be emphasized during residency for the overall management of the patient. Thank you.
Just I wanted to ask you, did you check for lead Alexa? What is the status of lead Alexa and lacrimal pathway? Like-
Yes, so it's protocol for us to do sac syringing before we post a patient. So before the operation, it was patent. So we don't think that was the cause of the infection. After investigation, what we realized was the tubings that were used for the vitrectomy, we had a lot of cases posted back to back. So there was a problem in our autoclaving procedure. So that was the cause.
Thank you. Dr. Shubham Saurabh. His topic on recurrent preceptal cellulitis in a child with superior rectus myocystic sarcosis, a case report.
Good morning, everyone. Myself, Dr. Shubham Saurabh. I will be presenting a case report on a recurrent preceptal cellulitis in a child with a superior rectus myocystic sarcosis. Cystic sarcosis, as you all know, is a common parasitic infection caused by larvae of Cystotina solum, commonly known as pork tapeworm. Infection generally follows through the intake of contaminated pork or water. In ocular cystic sarcosis, spreads via the ophthalmic artery branches. Coming to the life cycle, there are two hosts for this larvae, human and pig. The definitive host is human. As we ingest the embryonic egg, it hatches into oncosphere and then goes to intestinal walls, and then penetrating through that, it enters through the systemic circulation. Orbital cystic sarcosis is mainly divided into two, myocystic sarcosis and the orbital one, out of which 80% cases are reported of myocystic sarcosis. Frequency of muscle involved, most commonly involvement is in superior rectus, followed by other rectus and the obliques. Also, rare cases of lacrimal sac cystic sarcosis has also been reported. Patient may present with periocular swelling, diminution of vision, ptosis, proptosis, lacrimal symptoms, diplopia, or strabismus. It could easily be differential diagnosis could be cellulitis or other tumors, hiatus cyst, or most commonly superior ophthalmic vein thrombosis. Our patient was a 12-year-old male child who was belonging to lower socioeconomic strata and had a history of unhygiene conditions. So the chief complaint was recurrent swelling of right eye with partial drooping of eyelids since past 1 year. Also, intermittent episodes of redness and watering was present. Apart from that, best corrected visual acuity was 6 by 6 parts in both eye on distance distance shot. Examination showed restriction in elevation and sluggish reactive reaction to light. Otherwise, slit lamp and fundoscopy showed normal and anterior and posterior segment. Blood investigations were done. Eosinophilia was noted. On ultrasound, USG, right eye showed was query cysticercosis, so we proceeded with CCT as well as MRI brain plus orbit report, and it revealed a cystic swelling of 1.34 into 0.7 centimeter of cyst in the right superior rectus muscle. We immediately proceeded with the treatment part and started the patient on steroid tab prednisolone with a tapering dose. Along with that, we also gave antihelminthic tab albendazole for next 4 weeks. Patient was followed up closely and he was found to recover pretty well. So the discussion shows that the diagnosis of this disease is actually based on a tripod of all clinical, serological and radiological findings, apart from which the imaging studies are the most helpful and to establish the diagnosis. Since it's belonging to those who are in lower socioeconomic strata or are unhygienic, so therefore prevention by health education of population is an important aspect. Along with that, imaging plays an important role and patient recovers well with the course of steroid as well as antihelminthics. Close follow-up is necessary for compliance of the patient. Thank you.
Just I wanted to ask, like, do you ask for any food habits?
Yes, sir. So he was also a history of eating raw mud, the pica and everything. And he was non-vegetarian by choice. So eating pork must have been there.
Yeah, it's very important to ask.
Yes, thanks.
Just a comment on that. It not only is eating pork, it's even eating not properly washed salads.
Yes, ma'am.
And you
Green
will see
vegetables.
it
Yes,
in
spinach
even
and
high socioeconomic people because they can afford the salads.
Yes, sir. Yes, thank you.
Dr. Varsha, Dr. Govind Prakash. Yeah. Dr. Sarbik Day. Dr. Sarbik Day, I have a topic analysis of posterior segment cause of 50 patients for the disability certificate in a tertiary eye care.
Good morning, everyone. My topic is comprehensive analysis of 50 patients with posterior segment pathology seeking disability certificate at a tertiary eye care hospital. This study explores the substantial impact of posterior segment eye disease on visual impairment, prompting individuals to seek disability certificate for visual blindness in India. Certification for visual disability in India involves a voluntary process with a minimum 40% disability requirement. As you can see, based upon National Survey of Blindness, 5% of the patients who are opting for disability certificate for blindness are for posterior segment pathology. Materials, the study design was a prospective observational study in a medical college hospital in Mumbai with a total duration of 4 months with sample size of 50 patients. Instruments and gadgets that were used were indirect ophthalmoscope, direct ophthalmoscope, slit lamp with 90D, B scan and OCT scan. All the patients who had posterior segment pathology were included along with patients who had given their consent. For exclusion criteria, we didn't consider the patients who had anterior segment pathology as well with media opacity in which fundus cannot be examined. The various diseases that we encountered were macular degeneration, retinal detachment, amblyopia leading to nystagmus, optic atrophy, retinitis pigmentosa, thicycle eyes, CNVM, Stargardt's disease and coloboma. As you can see from this pie chart, the burden of the disease, most patients were from amblyopia pathology with optic atrophy following next, with retinitis pigmentosa, macular degeneration, and diseases like Stargardt, CNVM were relatively in less number. We did a demographic survey where we found that males were more likely to develop optic atrophy, retinitis pigmentosa, macular degeneration, while females presented more with thicycle eyes, and amblyopia like pathology were equally presented by both genders. Age-wise distribution, we found that below 18, congenital eye diseases such as coloboma, nystagmus, amblyopia Retinitis pigmentosa were more among below 18 candidate patients, and optic atrophy and thicycle due to trauma or macular degeneration were found to be more in patients above 18 years of age. Discussion. In this study, we find that the posterior segment pathology, notably like we saw in the graph, nystagmus, optic atrophy, RP, and macular degeneration account for majority of the underlying causes for patients seeking disability certificate. In sex distribution, males were twice more likely to opt for disability certificate due to posterior segment pathology, and under 18, nystagmus and retinitis pigmentosa was the more common causes. There has been substantial decrease in the number of blind patients from 1997 to 2020. At least 50% reduction has been noted, but this is restricted to anterior segment pathology and cataracts and refractive errors. Now research is more needed to minimize the impact of blindness and impairment due to posterior segment pathology. In conclusion, these kind of studies where posterior segment pathologies are highlighted more will give government a better understanding of how to deal with these patients and how to enhance the patient care and diversify the challenges and solve them. Thank you.
Dr. Govind Prakash. Dr. Varsha. Thank you so much for all presentation. It was all wonderful presentations.